Welcome to today's presentation entitled Unwanted Thoughts and Behaviors, Understanding OCD and Its Treatments. My name is Dr. Gary Zamet. I am the President and CEO of Clinilabs, which is a contract research organization based in New York City that conducts clinical trials in a variety of therapeutic areas, including in the area of obsessive-compulsive disorder. I prepared a presentation for you today that will give you a basic understanding of obsessive-compulsive disorder, how it's diagnosed, its prevalence, its causes, and its treatment. And I'll also spend some time talking to you about some of the new experimental treatments underway for this condition. So let's begin. What is obsessive-compulsive disorder? Obsessive-compulsive disorder is characterized by the presence of obsessions, compulsions, or both. We're going to define obsessions and compulsions momentarily, so bear with me on that. The obsessions or compulsions are time-consuming. So the sufferer of OCD will spend more than 1 hour a day engaged in these obsessions or compulsions, or they will cause significant distress or impairment in functioning. Now, the obsessions and compulsions are not attributable to the effects of a substance, either a medication or an illegal or recreational drug or alcohol, and not due to another medical condition. The diagnostic criteria that I'm presenting to you now are the criteria that are represented in the diagnostic manual that is used by the American Psychiatric Association called the DSM-5. So this definition is a standard definition that is applied throughout the fields of psychiatry and psychology in the United States today. So let's talk about the obsessions and compulsions. What are obsessions? Obsessions are defined by recurrent and persistent thoughts, urges, or images that are intrusive and unwanted. These thoughts can range from things so simple as, I believe that my hands are dirty. I believe I'm going to catch germs by touching this object. Or thoughts that can be so damaging. I believe that I'm going to do something harmful. I believe that I must be a bad person. Any number of beliefs that can come into a person's head, or images ranging from all kinds of things. But the point is that whatever the thought or urge or image is, it's really an intrusive image or thought and unwanted by the person who's suffering from it. Secondly, the individual attempts to ignore or suppress such urges or images or thoughts and try to neutralize them. In other words, try to make them go away. I don't want these. I want to get rid of them. And as we discussed in the prior slide, if a person is engaged in these obsessions for at least an hour a day, you can see how time-consuming and exhausting it can be to have these unwanted thoughts, urges, images, and then be invested in trying to get rid of them over and over and over, trying to get them out of your mind, sometimes trying to think about other things, but yet these thoughts keep coming back. What are compulsions? Well, compulsions are defined by repetitive behaviors, such as hand washing, ordering things, putting things in a certain order, checking things over and over again, or mental acts such as praying or counting or repeating words to yourself silently. Compulsions are a little bit easier for us to recognize than obsessions because they're so obvious. Hand washing is the cliche behavior that's engaged in and characterized by people with obsessive-compulsive disorder and thought to be so characteristic of the disorder, where people may wash their hands over and over and over again, even though they know that their hands are clean. They wash over and over to the point that their skin is raw and rubbed red. They may order things on their desk, order things in their closet, order things as they're sitting in a restaurant having dinner. Things must be put into a specific order, and there's a certain anxiety that arises if things aren't ordered in such a way. Checking things to make sure that the gas is off on the stove or that the door is locked. So with these compulsions, there comes a sense of anxiety that is disturbing to the sufferer. And the sufferer will then engage in behaviors or mental acts that are aimed at preventing or reducing the anxiety or distress that they experience. So these are considered compulsions. Now, how common is obsessive-compulsive disorder? The lifetime prevalence of OCD is between 2 and 3% in adults. There are similar prevalence rates in children and adolescents. And when research is conducted with people in other geographic areas and other cultures outside of the United States, such as in Europe, Asia, or Africa, we see that there are similar rates of OCD in those areas. The gender ratio of OCD in adults is about 1:1. So about 50% of OCD sufferers are men and about 50% are women. In children, boys are a little more likely to suffer from OCD symptoms than girls. These are some important OCD statistics if you're interested in understanding more about the disorder. OCD symptoms typically begin in children. They commonly onset between the age of 8 and 12 years. Now, younger children can exhibit symptoms, so that is possible. But the most likely years in which a child will begin to report symptoms, if they have them, will be between 8 and 12 years old. In young adults, the disorder typically onsets in the late teen years or early 20s. So I think the average age of onset in adults is around the age of 22 or 21 or so. Over 60% of people who have OCD will experience symptoms before the age of 25. Middle age is less common, and it is even rarer in later life. Interestingly, the diagnosis of OCD usually is not made for several years. This may be because the OCD sufferer attempts to suppress their symptoms and tries to live with them before reporting them to a medical doctor. So there's a sense of embarrassment, a sense of anxiety and tension about having symptoms. So people try to live with it themselves and control the symptoms themselves for several years. Also, there may be instances where the OCD symptoms begin kind of mildly, and it takes time for them to become more severe and be recognized by others as well as medical professionals. So we don't know if race is a factor or if there are specific racial groups that have OCD more than others, but there is some suggestion that race may be a factor in the development of OCD symptoms. One thing that I will comment on is that as we understand OCD, obsessive-compulsive disorder is very different from having a kind of obsessive-compulsive personality. The obsessive-compulsive personality is someone who is very detail-oriented and detail-focused, someone who really sweats the small stuff. And those people tend to be able to put their obsessiveness or their compulsiveness into service. Very often they find jobs or careers where those traits are highly valued. They might go into medicine, they might go into accounting, or they might go into other types of work that require detail focus. That is not OCD. OCD specifically relates to these unwanted and intrusive thoughts and these persistent, repetitive, and unwanted behaviors that can be so debilitating for the sufferer. Now, what causes OCD? Well, we do know that OCD appears to be a brain disorder. There appears to be a problem in the communication between the front part of the brain and deeper brain structures. So for the OCD sufferer, it's important to know that there's nothing that you did that brought your OCD on. It's not your fault. This seems to be a hard wiring problem in the brain, and one that the OCD sufferer cannot control. We do know, as further evidence that this is kind of a hard wiring problem, that there is a genetic component to OCD. About 30% of teenagers with OCD have a first-degree family member with the condition. This means a mother, father, brother, or sister also with OCD. And when we look at twin studies, the twin studies show that 80% of twins may have OCD together. So if one of the twins has OCD, there's an 80% chance the other will have it as well. OCD is different from a disorder called PANDAS, which is a type of obsessive-compulsive symptom pattern that occurs in children after streptococcal infections. That type of problem has symptoms that will dissipate over time. It is not technically OCD. So treatments for OCD really have focused on the understanding and awareness that the neurotransmitter serotonin is involved in OCD. Serotonin is one of many neurotransmitters in the central nervous system, and it appears that medications that modulate serotonin level, like the serotonin-specific reuptake inhibitors, are effective as treatment. Now, the SSRIs, as you consider this list, you can see are typically considered antidepressants. That's how they were first developed. So drugs like Prozac, Celexa, Lexapro, Paxil, Zoloft, all have been used in the treatment of OCD. Although they were originally developed for depression, they've been used with some success in OCD. And since these drugs are specifically directed at modulating serotonin levels, making more serotonin available in the neuron, we know that this transmitter is involved. Unfortunately, though, only about 40 to 60% of patients respond to medication with significant reduction of symptoms. So while all of these medicines have been used as treatment for OCD, they are not the ideal cure-all treatment. Only 40 to 60% of patients respond to this significant reduction. And there are treatment-resistant OCD cases that just don't respond to these types of medications at all. But medication is not the only treatment option for people with OCD. Cognitive behavioral therapy is an effective treatment. Now, interestingly, the cognitive behavioral therapy, or CBT, really takes advantage of the insight that OCD patients have. Remember when I said earlier that the thoughts that people have, the obsessive thoughts that people have, are unwanted and intrusive, and the behaviors are unwanted and intrusive. So people recognize that these things are excessive. They don't want them in their lives. And being able to leverage that insight is critically important and valuable in getting them to think about their symptoms differently. So the CBT treatment may help a person change their belief about their environment or about their symptoms so that they can begin to recognize and change their behavior. So on a very simple level, if someone believes that their hands are dirty or germ-infested, or that touching something will create a germ infestation in their hands that requires them to wash and wash and wash, working with them to change their cognition, to change their belief system, can be very helpful. As part of CBT, the treatments can involve placing the patient in a situation that evokes anxiety, associated with the symptoms of obsessions and compulsions, and then working to modify those reactions, working to modify the patient's thinking about their obsessive thoughts and change their patient's behavior in response to compulsive behavior. Now, traditional psychotherapy or talking therapy has not been particularly effective in targeting OCD, but it can provide support as people are going through a CBT treatment. One of the things that the research has shown is that CBT can be combined with medication, and many people would argue that it should be combined with medication used in conjunction for the most effective outcomes in therapy. Now, there are many videos available that give you an idea of what a patient with OCD experiences, what life might be like for that patient. There are so many of them that show kind of the debilitating behavior of hand washing or of checking. And there are so many of them out there, and those people truly are suffering. But I wanted to show you not simply that, but more of a unique video in which a very articulate person is describing her own experience with OCD. So I've selected one video out of dozens to present to you. It's just about 4 or 5 minutes, but we can watch it here, and I'll pull it right up for you.
I'm Diana, and I work for OCD UK, and I had OCD for 26 years. My earliest memories of the illness were when I was probably about 8 years old. The symptoms then were a fear of stepping on the cracks, and I don't know why this was, but it obviously made me feel physically uncomfortable if I did do that. So that was one ritual. Another ritual, which is the compulsion, is that I used to have a great fear that if I didn't say my prayers so respectfully and sincerely, that my mother might be killed in a car accident. And it's taking on this huge responsibility as a child for another person's life. A lot of people know about the hand washing and the checking, but a lot of people are unaware that OCD can also take in a rather sinister angle where you can have a fear that you may harm very violently your own children, and it is the most horrific thing to go through. When I had my 4th child, I used to have intrusive thoughts in when I used to go to bed, that I would go to the children's bedrooms in my sleep, take out their dressing gown cords and strangle each one. And this was the most horrendous thing to have to go through, because I didn't know whether I was going to do it or not. I was permanently exhausted. So that was the obsession, but the compulsion was to try and relieve some of the pain and the terror that I was going through because of the thoughts, was to get out of bed, go and find their dressing gowns, take their dressing gown cords out of their dressing gowns, tie the cords in as many knots as possible, thinking I won't be able to actually put the cords around their necks. And then I'd go back to bed and I still couldn't sleep, and so I would have to get out of bed again, get the dressing gown cords, put them into a bag, seal the bag, put the bag in a high cupboard. And again, this would give a little bit of relief, but it was still terrifying. People with OCD are not dangerous and they do not harm, but you cannot get over this alone. You must go and speak about these ghastly thoughts to somebody. After I'd seen my doctor, I saw a very, very good consultant psychiatrist, and I was put on antidepressants, which helped me enormously. I had the medication combined with CBT. The antidepressants gave me the strength to sleep and eat well, so that I could then have my cognitive behavioural therapy, which is a psychological treatment. It deals with the here and now, and it doesn't go into your past, doesn't focus on your childhood. And it's the most wonderful treatment. So with the antidepressants and the cognitive behavioural therapy, I was able to put my heart and soul into my own recovery. I often used to say to myself, what is wrong with my memory? Why can't I remember whether the gas has been turned off? Because I would have checked 13, 14, 15 times, and I only checked 10 seconds ago, but still I'd be saying to myself, what is wrong with my memory? Well, in fact, people with OCD, they have a perfectly accurate memory, but what we don't have is a confident memory, and this is where CBT can come in and help restore that. I run a support group in East Sussex, and I find that they're actually very powerful, and it's wonderful to see people coming together and perhaps for the first time ever talking about, disclosing their inner thoughts that they've had hidden for years and years. I think support groups are very powerful, and for some people being able to meet someone else with a condition is gives great relief, and immediately there's a bond there. You can talk about things, share the thoughts that you've had, and also talk about just your own experiences. I'm just so grateful that I had a very, very good psychiatrist, and I had enormous support. I feel less tired because I was perpetually exhausted. I can now enjoy my days, and if I have an inappropriate thought, I can dismiss it by thinking, this is OCD, and that's just a thought. There is so much help out there, and there is good help. Things are improving all the time.
So that video was informative because the person describing OCD was really describing many of the different types of symptoms and experiences that the OCD sufferer goes through. It is really that sense of exhaustion that she is describing, because the symptoms can be so persistent and so troubling. And I think you also heard from the person in the video that the combination of antidepressant medicine, or the serotonin medicine specifically, and CBT was helpful for her. But as I said, the antidepressant medicines are only effective in about 40 to 60% of people. Therefore, pharmaceutical companies are pursuing novel treatments for OCD There are several under development, and there are some under development that don't act at the serotonin receptors. They have a different mechanism of action. And the thought is that these drugs may be used to augment medications that are currently being used that act at the serotonin receptors. So theoretically, one would get the typical serotonin medicine, and then added to that would be this second experimental medicine that is being tested to determine if the response to medication can be improved upon with this so-called augmentation or addition of a second medication. Studies such as this and studies that we're conducting at Clinilabs are seeking people who are adults with obsessive-compulsive disorder as defined by DSM-5 with the symptoms that I described to you, who are on a stable dose of a serotonergic antidepressant medication for at least 12 weeks. They have to have OCD symptoms of at least moderate severity when assessed on a standardized scale. That's because we need to see symptoms at the beginning of their treatment while they're on the one medicine, and then see if the symptoms will improve when the second medicine is added. No other significant medical or severe psychiatric conditions can be allowed, but people who suffer from mild depression are allowed. This is important to note because the people who suffer from OCD often have concurrent depression. That is, they are depressed at the same time that they have the OCD symptoms. These two disorders can go hand in hand, okay? Sometimes it could, and we don't fully understand what is behind it all. It could be that there's an underlying physiology that is pushing forward the OCD symptoms and also pushing forward depression. But sometimes it could simply be that people are experiencing their horrific OCD symptoms and then reacting with a sense of depression and low mood. So people with mild depression are allowed in the program that we're currently running. The treatment period is about 19 weeks. Now, for those of you who are interested in pursuing clinical trials, there is a nationwide directory of all of the studies that are being conducted in this particular therapeutic area. That can be found on clinicaltrials.gov. If you go to that website and type in the keywords obsessive-compulsive disorder or OCD, you'll see a listing of the trials that are currently being conducted in the United States. If you're interested in trials at Clinilabs, you should know that studies are anticipated, and we are currently seeking subjects with OCD. Our database is active, so candidates may be contacted at any time. If you're interested in participating now or in the future and want to enter into the database, you're welcome to do so. For more information, you can contact us by telephone at the number listed here. You can visit our website, or you can send an email to participate@clinilabs.com. You can send a text that says volunteer to 313131, and we do accept walk-ins at our clinic. Thank you very much for listening to this webinar on OCD. I hope that the information I've provided has been helpful to you in understanding how OCD is defined, how common it is, its causes, and its treatments. Thank you very much. We do have a couple of questions which I can take. The first question is, we see OCD in people as young as 4 years old. Have you seen this? Yes. In fact, OCD symptoms can occur in children as young as 4 years old. As I mentioned earlier, the typical age of onset is between 8 to 12, but that's not exclusive. So younger children can exhibit symptoms. In younger children, the symptoms may be slightly different because they may not be able to articulate their experiences as well as older children or adults can. So the observation by parents and other adults and healthcare providers is very important, and talking with the child to understand the nature of the symptoms is also important. Another question, what is the difference between Tourette's and OCD? Well, Tourette's is a tic disorder in which there are certain behaviors in which the person engages in uncontrollably. These behaviors come on kind of spontaneously. They don't seem to have the same type of drive behind them as compulsions do, which, as you saw in the video and you've heard from me, seem to be directed at reducing some level of anxiety and psychologically geared to address some particular need. The tic disorder is independent of OCD. There are, though, to be clear, there are some people who suffer with OCD who also have tics, and that has to be considered. The next question is some amount of OCD actually good for you? Well, being detail-oriented, being attentive to details, or the quality of your work, or focusing on the small things, those characteristics can be very valuable in today's world. You can employ those qualities in the service of your work. You can employ them in the service of doing things around the house, getting your taxes done, writing your checks accurately, and balancing your bank book. All of those things are positive aspects of being detail-oriented. That is not the same as having OCD. Keep in mind that the OCD symptoms are really intrusive and unwanted. The thoughts can be very bizarre, as you heard in the video, that you have to pray in a certain way, or if I don't do something, harm is going to come to myself or someone else. Those symptoms are really not good for you, and you really can't put them in the service of anything else. Okay, I think that's all the time we have now for questions. So I will thank you all for your attention today, and if you do have further questions or would like to inquire about the clinical trials that we're doing, please don't hesitate to call us. Thank you very much.